Cool. So hello everyone, thanks for coming. Obviously, if you have any questions, interrupt at any point or put something in the chat, and we can all try our best to answer, because I can't promise I'll have the answers. So we're going to start with some anaesthetics. I think if you're wondering like where to spend the bulk of your time revising at this point in the year, anaesthetics should probably be towards the bottom of your list. I don't think it's very high yield, but anyway, there's about 6 or so questions that highlight some of the main points that might be worth learning. So yeah, can we next slide, please? This first question. Myrna is an 18-year-old woman. She presents to the GP with abdominal pain consistent with appendicitis. She is sent to ED where she is assessed and the diagnosis is confirmed. She has no past medical history or surgical history of note, and she's currently studying for her finals and says she's gained weight and is now obese. She doesn't smoke or drink. What's her ASA score? Feel free to just shout out or put things in the chat or not, and we'll just go through it. Okay, should we reveal the answer? No one's.
Is it 2?
Oh, there you go. Well done. Yeah, it is 2. Next slide, please. I think it goes through a little bit. So I don't think I've ever seen UCL ask a question about ASA scores, but the online question banks seem to really like it. It's just worth learning. So I guess, yeah, 2, multisystemic disease, that's like obesity, smoking, drinking, well-controlled diabetes, hypertension, that sort of thing. ASA 3 is more severe disease, so like poorly controlled diabetes, hypertension, COPD, morbid obesity. I think BMI more than 40 puts you into 3. And then 4 is systemic disease that's a constant threat to life. So that might be like a recent MI, or severe heart problems, basically, is most of it, or like sepsis, something like that. ASA 5 is someone in an emergency, so maybe like a ruptured AAA or a big trauma. And then 5 is an organ donor, essentially. Yeah. So can we move on to the next one? The anaesthetist performs an airway assessment on a 34-year-old woman pre-op. She notices that she can only visualize the base of the uvula and the soft palate when the patient opens her mouth wide. What Malampati class does this correspond to?
I can't remember the scoring for this one, but I'd probably guess C.
Okay, should we have a look? Well done, good guess. Next one, please. Yeah, I'm not sure how useful this knowledge is as well, but it's not that hard to learn. So essentially, it's just used to predict how difficult it will be to intubate someone. And also, I think the higher the score, the bigger the risk of sleep apnea and things like that. So yeah, I mean, if you want to learn it, but I don't think it will be that useful as an F1. Should we move on? Okay, so Pierre is a 68-year-old man who is scheduled to undergo an elective laparoscopic prostatectomy in 6 weeks' time. Which of the following is most important to ascertain during pre-assessment?
I think I put E logically, but I know that A is used quite a lot by anaesthetists. Sort of if you can climb a flight of stairs, you're sort of looking pretty good surgery-wise.
Anyone else got any suggestions? Okay, should we have the answer? Yeah, you're right. I think this is quite a hard question because all of those things are quite important. I didn't write these questions, by the way, so I think they're all important, but I think that you're right. They love this flight of stairs business. I think it's a good predictor of like cardiovascular health and all of that. We'll go through a little bit in terms of the other answers. So anticoagulants, that's also important, but we'll talk a little bit about when you should stop certain drugs in a few questions. I think the reason it's this one is because potentially the other ones are more acute and like this is 6 weeks before the surgery. So I guess I don't really, to be honest, I'm not entirely sure about this question. Does anyone else have any insight? No. Okay. Yeah, just go for that one if you see it. So a 65-year-old woman has just undergone an elective hysterectomy. She's being looked after on the ward by F1. Her post-op blood test results come back in the morning, 2 days after the surgery, just before the ward round. And these are the results. And then what's the most appropriate next step?
It's a bit tricky without knowing any obs, but probably without knowing her obs, I'd maybe go for blood cultures just on the basis that she's got high white cell counts and low hemoglobin. See if we can find out if it's infected.
Okay. Any other suggestions? Okay, should we have the answer? So I think you fell for the trap that the question was getting at. The learning point being that these blood results are actually quite normal post-operatively, especially in the first like 2 to 3 days post-op. So to have slightly low hemoglobin from the bleeding during surgery and a bit of a raised white cell count, along with CRP, just from inflammation, the body's trying to recover essentially. So I think you would want to do blood cultures if the results were a bit more dramatic than that. I don't think that's a high enough white cell or CRP for you to worry it because it's post-op, if that makes sense.
Yeah, that makes sense.
But yeah, no, I mean, that's what I think they wanted you to say, if that makes sense. Yeah. Cool. So when should the combined oral contraceptive pill be stopped before surgery under general anesthesia?
Is it
I
D?
think it's a month before. Yeah.
Yeah, well done. So this is just something I think probably the most important thing from anaesthetics to learn. I think this one could actually come up. Yeah, it's 4 weeks. So for the next slide, I think it's got. Yeah, so I think worth learning this slide. I mean, yeah, ACE inhibitors, ARBs, day of surgery. Anything with estrogen 4 weeks before, just because of the risk of VTE. Warfarin 4 to 6 days before. I think aspirin, when it says can continue, I think that's probably a cardioprotective dose of aspirin. You probably want to check. Again, an F1's not going to make any of these decisions, so I wouldn't worry too much about it, but I think QuestMed quite likes asking these. Yeah, I won't go through it in detail, but next one. So a woman undergoing surgery under general anesthesia involving suxamethonium suddenly becomes rigid and hypothermic. What is the mode of inheritance of this condition?
I can't remember the name of the condition, but I'm pretty sure it's I'm pretty sure it's B, but I might remember it wrong. I know it's definitely hereditary.
Any other takers? Or should we review? Nearly. Close. I hate questions like this. I think it's just, yeah, just gotta learn it. This one's also more dominant. Next slide has a bit about it. So it's called malignant hypothermia, very rare. Happens with suxamethonium. The other one it also happens with, I think, is so halothane or something like that. there's a few other gases that can do it. And essentially, yeah, the question will just describe hypothermia and rigidity. Manage it with dantrolene. I can't imagine you need to know much more than that. And yeah, autosomal dominant. So there you go. Any questions about that? I think that was the last anaesthetics question. So I think this is going to keep flashing up the feedback form, right? So don't have to do it now. Or is that the only time it comes up?
Yeah, I think it comes up again before my section as well.
Cool. So should we move on a handover for ENT?
Yep, sounds good. All right. So hopefully you can see and hear me. Thanks, Josh, for doing the slides. So my name is Maria, also one of the 5th year, so I'm going to be going through the ENT section. If you have any questions, feel free to pause. So as you notice, ENT, anaesthetics, and VASC is all 1 week, so you're not going to get too many questions, but hopefully we'll give you a good overview today of what you do need to know. So this is the first question. A 36-year-old male presents with 6-day history of a painful right ear. On exam, he's noted to have a full smelling discharge and endoscopy revealed crusting in the attic of his right ear. His left ear was completely normal. What is the most appropriate imaging modality to confirm the diagnosis? So this is a 2-step question where you need to first of all figure out the diagnosis and then figure out what the investigation would be. So does anyone have any thoughts or ideas?
Cholesteatoma, and I would say A.
A, yeah, very good. So cholesteatoma and A, absolutely. Spot on. So buzzwords here are the discharge, the fact that it smells quite oddly, and also the crusting as well. So cholesteatoma is a benign, non-cancerous growth, usually of the upper cells of the tympanic membrane. Does anyone know why we're worried about cholesteatomas?
Can it cause facial nerve palsy?
Yeah, so it can invade, absolutely, and cause nasty symptoms like a facial nerve palsy. Also, we're worried that it can invade into the mastoid area and also can potentially invade into the brain. So lots of structures there that are obviously too important to invade. So we do need to remove it. So just if you go into the next slide, you'll see what it looks like upon inspection. So remember that the cone of light is the reflection. So it tells you that the tympanic membrane is not bulging. So that's a good sign because that's a more middle ear infective sign. The way you know which ear it is, does anyone know which ear this is? Just by looking at the tympanic membrane?
The right?
Yeah, good. So different people do it differently. So personally, I look at the Malleus process. So if it's going to the right, it means it's the right ear. And also it sort of points towards the face. You can think of it as an extension. So it will always sort of lead you to the face. So this is the right ear in this case. But yeah, absolutely. Some people do it sort of like the inverse or some way. I don't know how other people do it, but so this on the right is an image of a cholesteatoma. So you can see it's characteristically in the attic, i.e. the top bit of the tympanic membrane, and that's why it kind of can invade upwards. And so the next slide goes over some imaging in ENT. So as a rule of thumb, so anything to do with head and neck, cancers, cholesteatomas, or skull fractures, we always have to do a CT head. Does anyone know of any signs of a base of skull fracture? What are the important ones we need to look out for?
Battle sign?
Is it
Yeah, good. So battle sign. I think someone else was saying something else.
mastoid bruising?
Yeah, so that's the battle sign, absolutely. So it's the collection of blood at the base of the skull, and you can see it at the back of your ears where the mastoid is. So it goes darker, and that's the battle sign, absolutely. Any other signs for base of skull?
Running.
Nice.
Sorry, there's a few people that said a few things. Say that again. Yeah, exactly, rhinorrhea. So that's fluid leak from the nose, so CSF leak from the nose. Good. What do we call it when it's fluid leak from the ears as well?
Arteria.
Yeah, very good. And one more sign for base of skull.
Raccoon eyes.
Yeah, exactly. So the eyes, very good. And what's the important thing that you must remember when you're doing A to E and someone that has a base of skull fracture, what is absolutely contraindicated?
A nasopharyngeal airway.
Yeah, absolutely good. That's an never event. Very good. So CT head, obviously for things that involve bone. So anything to do with inner ear pathology is an MRI, and that's because inner ear pathology such as acoustic neuromas or vestibular disorders you won't be able to see on a CT. And then things for neck lumps. So any lump, doesn't matter if it's on the neck or as you learn next year, so like scrotal lumps as well. Always ultrasound is the first line. You can think of hernias as well. The first line is always ultrasound too. And then in the case of a neck lump, the next line of investigation would be to do an ultrasound guided aspiration. But these are the first line imaging techniques in ENT. So going back to our question. So next slide. So absolutely. So this is a two-step question. So it is a cholesteatoma, of which you have to do a petrous temporal bone scan. Apparently that's on NICE guidelines. CT head is not specific enough because you're specifically looking at the temporal involvement. MRI, you won't visualize any bone involvement. You do need to image, which is why D is incorrect, and E does not exist. So if you put down E, it's quite sad. Okay, next slide. Next question. Any questions on that, by the way? Okay, let's move on. So 7-year-old boy is brought to clinic by his mother, who's concerned that he's been complaining of left-sided ear pain for the past 3 days. The left ear reveals a bulging tympanic membrane. Examination of the right ear is completely normal. His observations are all within normal range. He has no past medical history and no known allergies. What is the next step in management? So this one's actually a tricky one. So first of all, does anyone know what the diagnosis is? And what might be... Sorry, go again?
So otitis media.
Yeah, very good. So acute otitis media. And so the buzzword here is the bulging tympanic membrane. Absolutely. So that's your middle ear involvement. That's pushing on the tympanic membrane and it bulges out. What is the difference between acute otitis media versus otitis media with effusion?
The bulging tympanic membrane.
Yeah, so your tympanic membrane will bulge in both cases, but what would differ in the history?
Like it's perforated?
Yeah, potentially. But is the effusion, is that sort of like an infective process? What is that also known as?
Glue ear?
Yeah, exactly. So glue air, so that could just be fluid. It can be a post-infectious thing, but usually it's just fluid that's persisting. Once again, that's because the eustachian tube is quite short in peds. And as you grow out, it naturally sort of the fluid goes away. But it can be quite distressful to kids because obviously they can't hear for a few months potentially. They have to get audiology appointments, etc. However, acute otitis media is an infective cause, so treatment is with antibiotics. However, in this question, do we treat or do we not treat? What's the indication for treatment?
Is it if there's effusion?
Yeah, so there is infusion, which is why the tympanic membrane is bulging. But when is it serious?
It's been more than 3 days now.
Exactly. So the cutoff actually, I think officially is 4 days. I was looking at this today. So after 4 days, you start to prescribe antibiotics. So actually 3 days is not enough. So that's one of the features. So there's 3 more. What else? Why else might you want to prescribe antibiotics?
It's a
Is it
little
febrile?
kid.
Sorry, go again.
If they're febrile?
Yeah, so if they're really systemically unwell, you'd probably want to prescribe antibiotics, absolutely. And with that comes things like if they've perforated their tympanic membrane, you'd have to prescribe antibiotics. So that's point 2. What are the other 2 indications?
If you are under 2 years old
Yeah, so
and
you're
it's
going on
bilateral,
exactly. So if it's bilateral, that's the 3rd thing. So if you have bilateral involvement, then you'd prescribe antibiotics. And then 4thly, if you are young, that's true, but the cutoff is actually, I think, 3 months or something like that. So if you're under 3 months, then you prescribe antibiotics. But otherwise, acute otitis media is quite common. So you just manage it by reassuring the patient. There's no need to refer to ENT. There's no need to do audiometry. Remember, topical things are only for your external ear features, so it would not help with your middle ear disease anyway. And if we were to prescribe antibiotics, does anyone know what antibiotic and for how long would we prescribe it for?
Is it amoxicillin? I can't remember how long, maybe a week?
Yeah, exactly. So 5 to 7 days of amoxicillin. And if you're allergic to amoxicillin, what would be the second line?
Clarithromycin? I can't remember
Very
exactly.
good. Very good. And if you're pregnant and both of those things are contraindicated, then what would you prescribe?
This is just a guess, but doxycycline, I don't know.
So doxycycline is actually contraindicated in pregnancy.
Oh, no.
But you
azithromycin.
azithromycin, yeah. So erythromycin, sorry, not azithromycin, but erythromycin is usually the antibiotic of choice in pregnancy. So yeah, good. So hopefully that's clear. So in this boy, he doesn't have any of the 4 features that we were talking about. So it's not perforated, it's not bilateral, he's not under 3 months, and he's not systemically unwell. So therefore, the correct answer is you just reassure the mother. Obviously, use safety net. So if it does, if features do continue on for longer than 4 days, then you would get him to come back, and then you prescribe antibiotics. So on sorry, going back to the previous one. So this is what you'd see if you did an ENT examination. So that's your bulging tympanic membrane. So if you can see, there is no light reflex anymore, so that cone reflex, and that's because the tympanic middle ear is bulging out. And obviously this is quite distressful and quite painful. So next slide. Sorry. Thanks, Josh. So as we said, we assess the patient. So immediate antibiotics, we spoke about the 4 sort of implications, but otherwise you just give paracetamol, ibuprofen, safety net. If he has symptoms for longer than 4 days, tell him to come back. But otherwise, we don't actually give antibiotics because there's lots of side effects with antibiotics in younger kids. So it's a risk-benefit sort of thing. Any questions on that? Okay, next question. So a 45-year-old female presents to the GP with 4-month history of watery rhinorrhea and nasal obstruction. She's also complains that she has noticed she has been mouth breathing at night. On examination of her nose, she's noticed that she has a single polyp in her right nasal passage. Rest of the ENT examination is unremarkable. She has no personal history of atopy, but her sister is known to have asthma. What is the next best line step in management? So I'll give you some time to process that. So what is the single most important buzzword in this whole passage? There's lots of signs here, but what's the one thing that you really need to look out for in ENT?
Nasal polyps.
Yeah, exactly. And what's significant about the polyp?
It could be causing symptoms. It can be just removed.
Yeah, but what's also
Unilateral?
absolutely. Good. Absolutely. So next slide. So for ENT, oh, actually, we could go through these first. Basically, you need to urgently refer. And the reason for that is any unilateral symptoms in ENT is an automatic referral. So it's quite easy to remember. If you have something that's on the right side but not on the left side, you start to get concerned in ENT. If it's bilateral, you're not as concerned. So all the options A to D, which are listed, I mean, some are, some aren't, would be used if you had bilateral symptoms. So say if she just every morning she woke up and from both sides she just had lots of rhinorrhea, she was got difficulty breathing, and she had polyps in both sides, then that wouldn't be as serious as a single polyp. So the next slide. A unilateral nasal polyp is a red flag, as is most things in ENT which are unilateral. So if it's bilateral, you're not as concerned anymore, and it warrants an automatic ENT referral. So the reason why in the previous question and why I put Samter's triad in was because they mentioned her sister has a history of asthma, nasal polyps. So one of the things that comes up is people who are asthmatic that get aspirin, they sometimes develop nasal polyps known as the Samter's triad. So the way I remember it, this is kind of my mini mnemonic, is I rewrite the first three letters but change the M to an N, and then you can sort of reverse it. So when you reverse SAN, you get NAS, so nasal polyps, and then you forget about the N and you stick with the AS for aspirin and AS for asthma. So it's a stupid way of remembering things, but that's how I remember most of my degree. So hopefully that's helpful. So next slide, please. So these are all red flags in ENT for which we automatically do a 2-week wait referral. So all the throat and neck symptoms are all cancer symptoms, to be fair, as are the ears, nose, and mouth. The only thing with the nose, I think the CSF leak is a symptom of meningitis, which is why you'd refer. But otherwise, everything else is a 2-week wait. Also, if you have stridor, it's the same day, immediate referral to ENT. It's not 2 weeks. And does anyone know if stridor is inspiratory or expiratory?
Respiratory?
Sorry, I don't think I could hear you very well. Can you say that one more time?
Inspiratory?
Yeah, very good. And that's because stridor has the word, the letter I. So I inspiratory, whereas wheeze, you have lots of E's, and that's expiratory. So that's how I remember it. So stridor is always an inspiratory noise, where it's either hitting a really constricted airway, could be an infective cause, could be a swelling cause, etc. But yeah, absolutely. Okay, so next slide. So 17-year-old male presents with swelling. Oh, sorry, any questions before we continue? Okay, so 17-year-old male presents with a swelling on the right side of his neck, below the mandible and just anterior to the border of the sternocleidomastoid. You first noticed it a week ago. The lump does not move on swallowing or protrusion of the tongue. What is the single most likely diagnosis? Okay, so any ideas? So first of all, let's work it through. So if the lump was moving on swallowing or protrusion of the tongue, what sort of lump is that? Where is that originating from?
Is it thyroglossus cyst?
Yeah, exactly. So it has a thyroid origin. So that's why when you do your thyroid exams, and you ask the patient to stick out their tongue and then you palpate, that's what you're doing that for. So yeah, absolutely. So the fact that the lump does not do that means it's not thyroid origin, which is not, sorry, an option here anyway. So here the important thing is, first of all, the age of the patient. Second of all, the location of the lump. And third of all, what was the history of the lump? So if we go to the next slide, we can talk through all of these things. So the correct answer is a branchial cyst. So usually these are developmental cysts or lumps, which are seen in young adults, and they're usually formed in the anterior triangle of the neck. Commonly, they're triggered by upper respiratory tract infections, so they're corrected with antibiotics and then surgical removal if necessary. Dermoid cysts are midline bumps, and that's all I need to know about those. Parotid tumors are obviously found in the parotid region, and lymph node enlargement. So lymph nodes would be quite mobile, so they wouldn't sort of you'll be able to move them around above the skin or the fascia surface, so they wouldn't kind of just be there, if that makes sense. So the way you approach neck lumps in general, so next slide. Thanks. So as we said, age. So is it congenital? Is it something that people are born with? Do they develop it at a young age? If it's a young age lump, it's most likely to be infective or developmental. If it's something that develops in someone that's older than 40, then automatically you're thinking maybe 2-week wait referral with cancer. Then the location of the lump is very important. So if it's a midline lump, it's a dermoid cyst, and thyroid lumps tend to be in the midline. Branchial cysts are found in the anterior triangle. The way I remember that is AB, so alphabetically. So anterior triangle, therefore branchial cyst. So ABC, anterior branchial cyst. Dermoid and thyroid come later in the alphabet, so they're more midline. So hopefully, sorry, there's an ambulance outside. So hopefully that helps with just a mini mnemonic. And then finally, you take a history and you examine. So once again, if you have enlargements bilaterally in the submandibular parotid regions, you're more thinking about maybe a salivary gland involvement, such as an obstruction. Does anyone know what infection in childhood causes bilateral parotitis?
Mumps?
Yeah, absolutely. Yeah, very good. Very good. Absolutely, mumps. So you'll learn that more in peds next year. But well done. So if we go to the next slide. So this is a table they put in of the different lumps. To be honest, I probably don't know most of these still. I've never learned, I've never bothered to study them. I don't know if you have, Josh. But I feel like it's quite low yield for the time you put in. So I only know them vaguely. Maybe I should know them, but yeah. So for me, the important ones, so the brachial cyst, remember A, B, C. So anterior is brachial cyst, and then you have your dermoid and thyroglossal cysts in the midline. Anything else I haven't really bothered learning. Hope that's helpful. So next question. Thank you. So we have a 26-year-old male presenting with a 6-day history of a sore throat. He's noticed that in the last 2 days, his sore throat has gotten markedly worse and he now has developed a fever. He also complains of new onset pleuritic chest pain, which started this morning. On examination, he looks systemically unwell and is noted to have a swelling and tenderness over the jaw, over the angle of the jaw. What is the single most likely underlying diagnosis? So I'll be honest, I did not know what this was when I went through it the first time. So I think if you do know, then well done. But does anyone want to hazard a guess?
Quincy?
So tell me more about quinsy. So what sort of symptoms would you get with quinsy?
Well, no, I just started my ENT rotation, but I feel like it's a peritonsillar abscess, right?
Yeah, exactly. So it's a complication of what sort of infection?
I don't know.
I'm putting you on the spot, considering you've just started as well, but it's a complication of tonsillitis. Yeah. So so if you get tonsillitis, you're probably more likely to get swelling. You've probably been ill for a few days. You might have purulent bilateral discharge, might be really sore on swallowing, not eating very well just due to that, etc. But that's a good guess. Does anyone think it could be PE, and why would it not be PE?
I don't think PE is associated with the other symptoms mentioned.
Yeah, absolutely. So you would not have any of the jaw tenderness. You wouldn't have, yeah, well, sore throat. Well, I guess infection can potentially precipitate a PE, but yeah, you're right. Why is it not lymphoma?
Is it the lack of B symptoms?
Exactly, yeah. So what sort of symptoms are B symptoms?
Weight loss,
Yeah.
night sweats.
Yeah.
He does have a fever, but
yeah. So yeah, absolutely. And obviously you need a longer history probably to diagnose someone with lymphoma. And then does anyone know what sialadenitis is? Sialadenitis. So sialadenitis is the inflammation of salivary glands, commonly caused by viruses, or it could be an autoimmune thing as well. So actually, just by ruling it out, the answer is A. I did not actually know about this condition. So the condition here, so we've just gone through all of these, is called Lemierre's. Has anyone heard of Lemierre's disease? I personally haven't, but if we look in the next slide, so Lemierre's disease is a complication where young patients who have prolonged symptoms of pharyngitis, they can develop symptoms of sepsis and pneumonia following a sore throat. So what happens is if you're ill for a long time and you have a sore throat, then that can actually invade into the structures behind. So things like your internal jugular, and it could then spread and cause all these symptoms on the right. Personally, I think I don't think I've heard about this, to be honest. Apparently it's caused by a gram-negative rod, so that's why in option A it had those bacteria names. So the treatment is with antibiotics and occasionally anticoagulation just to get rid of those PE symptoms. But apparently is a complication of pharyngitis in young people to be aware of. Any questions on that? Okay. So does anyone know what hot potato voice, what is that a buzzword for? We briefly spoke about it as one of the answer options for the previous question.
Quinsy?
Yeah, exactly, quinsy. So what happens is that because your throat is so swollen that when you try to speak, your voice basically gets slightly distorted. I think there's meant to be a video on this, but I'm not really sure if it's going to work on the next slide. I think I tried it earlier, but so you just have this picture of a lady here instead. So yeah, absolutely. Hot potato voice is a complication of, remember, tonsillitis, which can then progress into quinsy. So quinsy, you're worried, you'd refer to ENT, and they'd manage with incision and drainage and antibiotics, whereas tonsillitis, not everyone gets that sort of what's the word? Management, I guess. Okay, next slide. So this is your inflammation of the salivary glands. So once again, we spoke about the different causes already. So viruses, remember we mentioned in peds, things like mumps. So mumps infect your parotid glands, cause neck swelling. That's a common buzzword, but you'll learn more about that next year. Things like stones in general. So within your salivary glands, you can get stones which obstruct the gland itself, and it causes the swelling, backstream of that. And also autoimmune causes. Does anyone know what autoimmune condition causes salivary gland swelling?
Sjogren?
Yeah, exactly. And what other symptoms would you see in Sjogren's?
Dry mouth, dry ears.
Yeah, exactly. Just absolutely. So Sjogren's is an autoimmune cause of salivary gland inflammation. Okay, next slide. So 42-year-old woman with hearing loss on the left. Very conveniently, the answer is on the slide. But does anyone want to talk me through how you approach these Weber's and Renee's questions? So first of all, how do we do these tests? So if you had a tuning fork right now, how would you do the Weber's test?
You pinch the tuning fork, and Weber, you put it in the middle of the head,
Yeah, good.
and you just ask the patient where they hear him more, if it's the midline or right or left.
Yeah, and what's the normal?
Midline.
Yeah, exactly. They would hear it equally on both sides. So if it lateralizes to the right, what are the two options going forward of the type of hearing loss and on what side?
Ipsilateral conductive and contralateral sensorineural loss.
Yeah, very good. So Weber's, if it lateralizes to the right, it means conductive hearing loss on the right, so on the same side, or sensory neural hearing loss, sorry, on the left-hand side, so on the contralateral side. Very good. So then, in order to figure out which one of these it is, you do the Renee's test. And what does that involve?
Just to check if you got conductive hearing loss.
Yeah, I guess it checks for both really, but how would you carry it out? So what would you do?
You pinch it and then you put it in the air or something, and then to the patient's bone.
Yeah,
Right?
exactly. So you'd pinch it and then you put it next to their ear and you'd ask them if they can hear it and when they stop hearing it. And then when they stop hearing it, you'd put it on just the back of the mastoid, and that's to test for your bone conduction. So the idea is that usually, so what is the normal? Do we hear bone conduction better or air conduction better?
Air.
Yeah, exactly. So usually air conduction is better than bone conduction. So that's the normal. And that's what we call a Renee's positive test, which annoyingly is normal. Okay, so even though usually in medicine it's the other way around. So if it's Renee's positive, that's a normal test. But if you have bone conduction, which is greater than your air conduction, so we call that a Renee's negative test. And if you had a bone conduction which is greater than air conduction, then what type of hearing loss is that suggestive of? So if you can't hear with your external ear because something's blocking your external ear, but as soon as you put it in your bone and everything conducts from the middle inner ear onwards, what sort of hearing loss is that suggestive of?
Sensorineural.
So actually conductive. So you can think about it as things like, for example, if you had, I don't know, a foreign object or earwax or something, right? So your whole external ear is blocked off. Okay, so you can't hear with the air because in order to hear air conduction, you would have to go through external, middle, inner, and then up to your brain, right? If you have something impacted in your external ear, then you won't be able to hear air conduction because that external to middle bit is blocked off. So then when you do the bone conduction, you can suddenly start hearing better because suddenly it activates middle, inner, up to brain, right? So that's all normal, if that makes sense. So if your bone conduction is greater than your air conduction, then it means it's a conductive hearing loss because you can't hear from the external in. But as soon as you can hear from the middle ear in, that's a conductive hearing loss because you're basically bypassing that earwax or whatever it is that's impacting your ability to hear at that point. So therefore, if your Renee's test is normal, i.e. your air conduction is greater than your bone conduction, then that's usually a normal sign, or it could be a sensory neural hearing loss. Okay, so just working through this question. The woman with hearing loss on the left, however, her Weber's test lateralizes to the right. So remember, the two options we have is conductive hearing loss on the right or sensory neural on the left. So her Renee's test is positive, so it's normal. So therefore, it's not conductive hearing loss on the right, because otherwise her bone conduction would be greater than her air conduction. So therefore, it's a sensory neural hearing loss on the left, so on the contralateral side. So hopefully that's clear. Does anyone have any questions about that? So the way I do it is I draw out someone, and then I put like a tuning fork on their head. And then first of all, I label which way the Weber's test goes, and then I write out the two options. So either conductive hearing loss on the right or sensory neural on the left. And then I look at the second test, so the Renee's test, to figure out which one it is. And remember, if it's conductive hearing loss, then your bone conduction would be greater than your air conduction. If it's not, then it's your sensory neural hearing loss that is the correct answer on the contralateral side. Yeah, so on the next slide, absolutely. So this is the sort of demographic. So you start with the Weber's and then you figure out which two options it is. So either conductive on the same side or sensory neural on the opposite side. And then you do the second test, your Renee's test, to figure out which one it is. So remember, if your bone conduction is greater than your air conduction, then it's a conductive hearing loss. So if it's not the case, then it's a sensory neural issue. Hopefully that's okay. I usually just draw it out, and that's helpful. Okay, so next slide. So now just a tiny bit on audiograms. So audiograms show air bone conduction for both ears. So your crosses and, well, not your crosses in this case, your should be your circles and crosses are usually your sort of air conduction, and then your sort of brackets that look like this are your bone conduction. So if there is a gap here between your air and bone conduction, does anyone know what type of hearing loss this is indicative of?
Wait, what's what in the diagram?
So this diagram here, so it's a good point. I've been trying to figure it out myself. I don't think it's conventionally labeled. Because usually the circle is your right ear. Then you have a cross which represents your left ear. Which I think they've done it with squares this time, and then your sort of staples are usually your right bone conduction, and then the other staple is your left bone conduction. But regardless of what it is, there is clearly a difference between the top and the bottom, and there's a gap, which we call the air bone gap. And that is indicates a certain type of hearing loss.
Conductive?
Yeah, very good. So if you have an air bone gap, then it's a conductive hearing loss. So remember, if you think about it that way, if you had a sensory neural hearing loss, it doesn't matter if it's through air or through bone. If there's something to do with your nerve, you will hear the same, right? Technically, doesn't matter what you do. Okay, so air or bone would be impacted because it all goes through the nerve back into the brain. If you had a conductive hearing loss, then you will have a difference between air and bone, because remember, your external air is impacted with something, so you can't hear what's outside in the air. But as soon as you go to the bone, it goes middle ear, inner ear, and up through the brain. So that's all normal. So that's why you get that air bone gap. So hopefully that makes sense. So next slide. Perfect. So this one here, once again, this is a classic picture. So this is someone that has more or less normal audiometry. So there's no air bone gap here. However, there is a very common condition which has this pattern of audiometry. Does anyone know what that might be?
Presbycusis?
Yeah, exactly. Very good. So it's just old age hearing loss. And that's because as you age, you can't hear higher frequency sounds. So you can ask maybe some of your older relatives and you could do a test. You could just pull up YouTube and you will be able to hear higher frequencies, but then people of older ages actually lose that. So this is exactly the type of pattern. So as you can see at higher frequencies, your ability to hear it drops down, because you require a louder noise to hear it. The way I remember that is that as you age, you just gradually sort of decrease in energy, kind of like the audiometry here. So this is quite a classic picture of that. And then next one. So this is another type of hearing loss. So it's very characteristic at about 4,000 hertz. There's a dip at the frequency there. Does anyone know what this might be?
Is that just normal?
So actually, if it was normal, it wouldn't necessarily, obviously depends on what age you are, but it wouldn't necessarily dip like that. And especially at that one particular frequency. So just to give you a bit of background, maybe for some tips, you can sometimes see this in relatively young patients. They don't have to be young. Usually they play a very loud instrument, or they might attend lots of concerts.
Noise-induced hearing loss?
Yeah, exactly. So I actually didn't really know this one, but apparently noise-induced hearing loss, you have that characteristic dip at 4,000 hertz. So that's another audiogram. I don't think you'll be asked this. But the next question, and I think this is the last one for ENT. So once again, these are your audiograms. So your circle in this case is your right ear. Your cross is your left ear. Your staple, one of the staples is your right bone. The triangle, I'm guessing, is your left bone. So what you're looking at here is this sort of characteristic notch. So it peaks at around 2,000-ish. And just to give you a few more hints, so usually it's seen in quite young people. And it's a condition that we haven't really talked about today. Does anyone know what the condition might be?
Is this otosclerosis?
Yeah, very good. Absolutely. So remember, very young patients with progressive sensorineural hearing loss is absolutely otosclerosis. So remember, it's a hereditary condition with abnormal bone remodeling. It has a lot of stapes involvement. So you have a loss of the stapes as the bone around it remodels and kind of fixates. But on the audiogram, we have this what we call the Carhart notch at 2,000 hertz, which apparently is a characteristic finding of otosclerosis, which I also didn't really know about prior to this. But hopefully these are helpful. The most common one you see is the air bone gap, the first one that we spoke about, and conductive hearing loss. And then the second most common one, I would say, is the one with old age hearing loss. Those two are the most important ones. But does anyone have any questions on ENT? Okay, so I think we have another feedback link on this slide. I don't know if, I think that's the last one we have. Is that right? So
Yeah,
now
it is. Yeah.
if you guys can fill it out now and maybe we can have a short break, that would be amazing. And then maybe we can grab some tea or something and come back in a minute. But thank you very much. If you have any questions, feel free to message us or email us.
Yeah, guys, well done for sticking through it. I'll try and be efficient. But yeah, please fill out the feedback form. It helps me MedSoc keep running these tutorials and making them better. But yeah, maybe we can come back in like 5 minutes and we'll just get through vascular. So yeah, see you then. Okay, hopefully you can all hear me. Thank you for filling out that form. So I'm going to be covering vascular. So my experience with vascular from last year is that it's not like the biggest chunk of the curriculum, but it's important to know the important emergencies and some of the like red flag signs. as well as some of the screening. So I believe we're going to go through some of that today. So we're going to go for a bit of about aortic aneurysms, aortic dissections, which are the big two conditions, and some other stuff as well. All right, so yeah, other stuff is just to know about. You could, I've never really seen this come up, but sometimes they ask you about examining a diabetic foot, so worth knowing for the OSCEs. Okay, so SBA 1. So this is a 66-year-old gentleman who comes into A&E with mid-back pain. He is clammy, confused, and observations are 37 degrees temperature. His heart rate is at 164. His resp rate is 24. His blood pressure is at 79/51. Oxygen saturations are 95% on room air. So you examine him, and there is an expansile abdominal mass. He's recently had a scan indicating a 5.6 centimeter diameter aorta. So what's the most appropriate next step? So if anyone knows the answer, just shout out. Otherwise, we'll go through it. No problems.
Is it D? No, I mean C.
Yes. So yeah, you're exactly right. Do you know what might be happening?
His AAA has perforated.
Excellent. Yes. So that's what they want here. And this is probably one of the big emergency presentations. So the key thing here, mid-back pain is normally the presentation. He's clammy. So this really indicates that he's basically losing blood. Clammy is where you're basically cold but sweaty. So he's cold because his peripheries are constricted, and so they're cold. But he's sweating because his sympathetic nervous system is pumping out this sweat onto his skin. That's good to know. Other thing to note is his blood pressure is dropped, and blood pressure is normally the last thing to drop when you're sort of losing blood. So this already shows you that he's basically in shock. So you're absolutely right. You want to get him, you want to sort of start getting over to a vascular unit, and you want to initiate something called the major hemorrhage protocol. So yeah, this is an emergency. So you want to do an A to E assessment, and then you alert vascular. So he's in shock, and something you can start to do when you're doing your A to E's is start putting in the provisions to get him some blood. This is what the major hemorrhage protocol is. So you want to provide him with some O negative blood. Patients can get up to from 10 to 40 units with a ruptured AA. And yeah, you might want to be trying to get, well, you will want to be getting some cross match and group and saves done when you're taking his bloods to prepare for that. And yes, something else to know is if you're unsure about the diagnosis, you can also possibly perform an ultrasound. But yeah, major hemorrhage protocol. All right. So this is the second SBA. Any questions on the first one? I'll try to answer best I can. Cool. All understood, hopefully. So second SBA, we have a 72-year-old male. He's come in with a 2-year history of an infrarenal abdominal aortic aneurysm, and he presents for follow-up. So he admits that he's smoking quite a lot, 20 cigarettes per day, despite being warned against this several times. The patient comes with a recently taken abdominal ultrasound. After the consultation is completed, the doctor believes that surgery may be required. Which one of the following options would be regarded as an indication for surgery? So I'll give you guys time to read that, but this is really about knowing basically some sort of the screenings and indications, which we'll go through.
Is it A?
Yes, it is. So basically this like little section here is the really important stuff. Oh, well, and I guess this bit here. So the screening program is for men over 65 years old, and they do it with an abdominal ultrasound. So you can go by the size of the actual aneurysm right now, and you can also go by how fast is it growing. Those are the two like ways that the risk is like set out. So if it's over 5.5 centimeters, this is where we're talking about an urgent referral. So this is a 2-week referral. 4.5 to 5.4, you want to monitor this every 3 months. And if it's between 3 to 4.4 centimeters, this is annual follow-up. And so when they drop all of these, I'm going to go back to the question. When they drop all of these things about his lifestyle, they're doing it for a reason, and they're really showing you, okay, this guy's got like cardiovascular risk factors, and to address those risk factors, you always want to start with conservative measurement as well, make sure that's covered to stop any problems basically deteriorating. So you'd want to get him with his diet and exercise sorted a bit more. Okay. Yes, and so symptomatic. So if he was symptomatic, much like our last gentleman, you want to start the A2E quickly and start thinking about how can we get this guy to surgery and basically save his life. So that's aortic aneurysms. Right, and in terms of the repair, this is how it works. So you're essentially putting in a stent, and from my memory, they do this. They put this through the femoral artery, and they bring this sort of device all the way up here, and they just open it up and keep this sort of channel to avoid this really risky zone of the aorta. Yeah, and if we're thinking about more of a complex or ruptured AAA, you'd be wanting to basically have an open surgical repair. Are there any questions about that second SBA?
For the last question, why
Yep.
did the patient need antibiotics?
So all the way over here. Yeah, I was looking at this. To be honest with you, probably just because they're going in for surgery and because they're basically probably not that healthy. But I'm not 100% certain on that.
Thank you.
No worries. Okay. So yes, there you can also get another type of aneurysm. It's kind of a rubbish name, but pseudoaneurysms. So these involve a different layer of the aorta. These are also called dissections of the aorta, and that's what they're more commonly referred to. Yeah, if you do an ultrasound, you'll see, like, as you can see here. Now, I'm not sure what the red and the blue exactly mean. I'm going to imagine it's direction of flow or speed of flow. But the point is that they're different in two sections of the aorta. And I guess they call it the yin-yang or Pepsi sign. So it's where there's basically a new compartment where blood isn't supposed to be forming. And that can cause problems, which we'll basically go on to talk about as well. But yeah, those are pseudoaneurysms or a dissected aorta. Okay. So this is the third SBA. A 72-year-old lady complains of a painful right leg. So you examine the leg and it's cold and the pulses are absent. She has many risk factors for atherosclerotic disease. The question here is asking, how would we best differentiate between an acute or chronic ischemia? So just give you a couple of seconds to read those options, and yeah, if someone knows the answer or thinks has an idea, just give us a shout. Okay. So it's basically the presence of the foot pulses in the leg. So if we go through, basically when something happens very suddenly and develops very quickly, you want, I guess, dynamic signs or signs that will change very quickly. So, the family history of claudication will always sort of have been there. It doesn't tell us about her health state. Neither would the 40, like her smoking history or, previous scars or a history of thrombotic stroke. You just want to know, you need a sign about something about what's changed right now. So yeah, although these are all probably risk factors that help you like maybe start thinking about what could be going on, but the important thing is the absence of foot pulses in the leg. Okay. So these are some causes of acute limb ischemia, basically. And I remember them talking about this. There's the concept of the 6 Ps: perishingly cold, pallor, pulselessness, with some paresthesia. Once they, I guess, because that there's a concept of 6 Ps. Once they start dropping in like 1, 2, 3, 4 words in an SBA, you can be you can start to be quite confident about what they're getting at. So acute limb ischemia is basically just very sudden lack of oxygen to a limb, and that can be you can see why that might happen from these causes. So thrombus, you get a clot. You can get an abdominal, so aortic aneurysm. So I guess one, it could rupture, and two is if it gets lower and lower down the abdomen, it can start to impact those arteries that branch out towards the limbs and affect their blood supply. So that's some causes about acute limb ischemia, and those are the 6 Ps, worth knowing for the SBAs. Okay. So does anyone know some investigations that might help you if you think someone's got acute limb ischemia?
Is ABPI helpful?
ABPI?
That's good. That's really good. Any others?
A full vascular examination?
That's good. That's good. I like that you started with like things that are going to start very imminently. That's really good. Like systematically start from, what we can do right now, examinations and these blood pressure readings, and then work up. Yeah, so you can definitely do that, and I would agree with you. You can also do a VBG to see if there's high lactate. If there's more lactate, there's less oxygen. A Doppler ultrasound, which again, depending on where you are, might be quite readily available, can help you just really confirm if pulses are there or not. And a CT angiogram, which is very expensive and probably a little bit more down the line. In terms of managing this, you can manage it by bypass or angioplasty. And if it's a thrombus, you can basically thrombolize or break down the clot that's causing this blockage. Okay. Any questions on that? Cool. Okay. Reperfusion injury. So yeah, this can happen when someone's had acute limb ischemia, and then you suddenly you start reperfusing their limb. So for this reason, it's important to monitor these patients after. So what happens is you suddenly increase this blood flow, and with it, you increase the oxygen to this limb that's basically been starved of it. And oxygen can cause free radical damage. So if you give all of this oxygen, it damages the tissues, then you can basically set off this inflammatory process, and as a result, you can get swelling, and it can lead to electrolyte abnormalities. So if a question asks you about this guy's come in, he's had an acute limb ischemia, now recovering on the ward after like an operation, and then you see they give you some results, and you can look out for some increased potassium, more H+, some myoglobin, or compartment syndrome. These might all be pointing to a reperfusion injury after acute limb ischemia. Okay. All right, we're on to SBA 4. So 65-year-old woman, she has type 2 diabetes and a 50-pack year smoking history. She's been suffering from intermittent cramp-like pain in her right leg for the past 3 months. It is worse when she walks approximately 500 meters and up steep hills. So what's the most appropriate management for this lady?
C.
Yes, good. So this is a lot of this is kind of, you can get there with some logic, but you're right. So diagnostic angiography, very expensive, and this woman's, in terms of her condition, like relatively okay. She can walk 500 meters up steep hills. You could start on propranolol, but there's a lot more. The cause of this problem is still there. If you reassure and follow up in 6 months' time, this could get a lot worse. She's got 50-pack year history and she's got diabetes, so this is the culprit here. So we want to try and stop this condition getting worse. And bypass surgery, again, like, it's a little bit too soon for that. So yes, this is intermittent claudication, which basically it'll present with this sort of cramping pain, and it'll be exacerbated by exercise. Really, a lot of this stuff you guys have already been mentioning before. You can start investigating it with the ankle brachial pressure index, which we'll talk about in a bit. And you can do this duplex ultrasound, which can sort of, again, investigate those pulses to see if there's any that are absent already. And I guess something, I haven't heard about this before, but you can get them to do a distance diary. I guess this is sort of, it gives you some kind of measure about what they can handle now and how bad their condition is. So good to do. And yeah, you want to stop them you want to stop the lifestyle factors, smoking, exercise, and you can give them some pain relief. You can give them some statins to lower their cholesterol, and you can give them clopidogrel. So we want to basically an antiplatelet. You want to stop their thrombotic risk with clopidogrel. But if this was maybe a little bit more critical in terms of her presentation, it's also worth referring to Vascular so that they can maybe start thinking about an operation. So yeah, this is what you guys are talking about, which is very good. It's basically a ratio between the pressure in your blood pressure in your ankles, and the blood pressure in your arms, I believe. So if the ratio is lower, it means your ankles are not as well perfused as your arms. So that could indicate that there's a mismatch there. And there are degrees at which you can classify this. So this could also be worth knowing, because it helps you understand what like treatment this patient might need. If, for example, if they had critical limb ischemia, you probably need to just refer them to Vascular. Maybe slightly more mild disease like this lady, you might just be trying to see if you can start conservative treatment first. Important one to remember is that sometimes it can be high, and the intuitive thing to do is sit there and think, oh, that must mean like their health is like not bad, it's decent. But if it's over 1, it could mean that their arteries are starting to get really firm and calcify, that can also be a bad sign. So remember, if the ABPI is higher, not necessarily good. Okay. I think we just went through this, so we'll carry on. All right. That's good. So does anyone know what any of these pictures are? If you know, just tell me what picture it is and what you think is causing it.
Is the top right one a venous ulcer?
Yeah. Yes. So this is a venous ulcer. They're often accompanied with like varicose veins. And these other ones here, if anyone knows them, they're arterial ulcers. So venous ulcers are the ones that are higher up above the ankle usually. They're going to be a little bit more wet looking. They're normally a little bit more red. And arterial ulcers are very neat by comparison. They've got these classically punched out appearances. They're going to be below the ankle, and they're going to be more painful. So that's how you differentiate the two. Okay. So SBA 5, 78-year-old gentleman presents with an ulcer. It's been present for 6 months, despite intensive management from the district nurse. So this ulcer is located in the gaiter region. It has a granulating base, and it is surrounded by eczema. His ABPI for the last 6 months has been between 1 and 1.2. So what feature in this history is most suspicious of malignancy?
D.
Did you say D?
Yeah.
Yeah, I'd agree with you. Oh, I believe probably, yeah, there you go. I'm guessing that's what these pictures are showing. So yes, yeah, the rest of these things I think could be part of like the normal part of an ulcer forming. But whenever you have an ulcer that has just been continuously present for 6 months, I guess it suggests that there's some kind of process sustaining that. So you know, ABPI just tells you about like her sort of the state of her arteries, basically the location of the ulcer, doesn't tell you that it's any different from a venous ulcer. It's granulating base, so that's, I guess, showing that it's getting a bit more inflamed. That could still be a venous ulcer. And the skin changes. So the skin changes we were looking at here are also just like still consistent with the venous ulcer, but they're not supposed to last for like 6 months. They don't tip, especially with treatment from a district nurse. So that's always there's something wrong there. Okay. So varicose veins, these are what's often like behind venous ulcer formation. They occur because basically the valves that help you pump the venous blood up against gravity are not working properly. This leads to the blood just pooling and sort of leaking out of those blood vessels. So you'll typically see that they'll look really what they call tortuous, really like kind of lumpy and gnarly looking. They'll be twisting and turning around in someone's calves, and you can also get a bit more itchiness because of the basically eczema that forms when you get these venous venous insufficiency. So management, you can get regular movement to try and basically squeeze these veins and get that blood moving up against gravity. Elevate the legs, so you just eliminate gravity, stop it just pulling the fluid, I guess, down towards their ankles. And you can give compression stockings to try and again tighten the area and get the blood moving up. So that's varicose veins. Okay, wow. Lymphedema. So does anyone know what lymphedema is? And does anyone know what might cause it?
Is it quite similar to varicose veins, but with the lymph vessels instead of the veins?
Yeah, that's good. That's pretty much it. You can break it down with like what the actual wording of it. So like lymph and edema, like swelling of lymph. And there's a lot of odd causes of it. I wouldn't like invest all of your time into this, but if you haven't some extra time, by all means learn this. It might get you a question or two more. But yeah, so common causes after mastectomy, if you're removing all of these lymph nodes, you can create a blockage in the lymph system, so you can stop the reabsorption of this liquid and it can pool. So these parasites, filariasis, I don't remember exactly what these things are, but I think they basically cause inflammation and scarring in the lymph system, and that causes a blockage. Varicose veins can cause lymphedema, as well as obesity. So basically, the earlier you treat this or treat the cause, the better chance you can of solving this problem, but it often persists. And there are various, from memory, there's various stages of lymphedema. At some point it's reversible, but beyond a point you can't stop this swelling from happening. So it's important to treat early. Okay. So now we've just got a case study. So I think this one has a CT for you guys to interpret, so that would be fun. So we've got a 56-year-old woman who comes in complaining of chest pain. This started 6 hours ago. It was non-specific in character. It doesn't go anywhere else. Her blood pressure is 118/72. Her heart rate is at 88. Respiratory rate is at 18. She's got good oxygen stats, 98%, and 36.8 temperature. She's feeling a bit nauseous. So you sort of delve into her history a bit more. She's got hypertension. She's got a 2-year PAC history. She's on antihypertensives in the form of amlodipine, and yeah, she's a mother of 2. So already you've got a picture of someone who's basically got cardiovascular risk factors, and obviously it's quite alarming presentation. So yeah, I guess you see this woman, she's got chest pain. It's not like barn door like angina or like MI, but from sometimes you can get atypical presentations. I think especially in women. So if someone's got chest pain and they've got these risk factors, you'd want to still be thinking about it. So they did an ECG here. Her ECG was normal, and her bloods were normal, including troponin. So that's what this TROP-T is. Does anyone know what troponin is?
I think it's an enzyme that indicates myocardial tissue damage.
Yeah. So it's like this protein that's just released when heart cells are like broken down. So this is, as it's seen in, as you say, myocardial damage or MIs as well. So as she starts to wriggle her back, she says she complains of this dull backache. Further observations, her chest is clear. She's got heart sounds 1 and 2. I don't really know what EDM means, but okay, that might mean nothing. If someone knows, do let me know. And she begins to feel a bit lightheaded. So there's something sort of stopping the perfusion of her head and brain, I guess. She's got normal abdominal exam, that's soft and non-tender, and she's got a normal neurological exam. So we're not thinking about, things like stroke or any of those things. Okay. So you do an echo and it shows something called a dissection flap. And then they do a CT angiogram. So this is a CT scan with a bit of contrast to help show us the blood vessels and see if there's something wrong. So now there's a bit of there's a series of pictures. I want you guys to basically try and shout out or tell me when you see something that's a bit weird. I'm gonna give you maybe let's call it 5 to 10 seconds on each frame, and there will be something there. Okay, so first frame. So I mean, here we're basically starting at the very top, right? And then we move progressively down. You can see that's the start of the lungs, I guess the lung APCs, and you can see the top of the humerus. So we're not quite in the chest cavity yet, but we're getting there. Okay, here again, we're just getting a little bit further down. There's certainly a bit of a, okay. Okay, So we'll go back. Coming down, like this is sort of top of the lungs, coming down, this is the aorta coming over, and you can start to see this should all be like one color basically. And as we go further, there's this just weird mismatching colors and this well sort of demarcated like border. Does anyone know what this is?
Is that the false aneurysm that we're talking about?
Yes, that's exactly what it is. And for plus points, so there's a bit of it that's like the normal blood, and it's a bit of it where it's the false, like the false compartment. Do you know which part of it is which?
The gray part is the false compartment, and the white part is the real one.
Yeah, exactly. So yeah, that's right. The brighter part is the blood, and I remember vaguely being taught once, like blood, bone, and contrast. So on X-rays and CT scans, these are normally the things that are brighter. So a brighter parts of the blood vessel will be fresher blood. As it becomes a little bit more, I guess, like hypodense, they say, it's more sort of static and clotting. And this is the same, by the way, if you're looking at like a neuro CT scan, and you typically, they tell you about subdural hematomas. If it's brighter, it's more like it's a bleed. It's quite an acute bleed. If it's getting a little darker, that blood's probably been there a little bit longer and it's not moving as quickly. So the false compartment is this bit. Okay, and yeah, you can see this is sort of two parts of the aortic arch. So this is a little bit higher up in the aorta, around where the heart and stuff are, or a little bit above it. Okay, so that's right. This is false aneurysm, pseudoaneurysm. It's a type A dissection, which means it's basically in the ascending aorta, so the bit literally just coming out of the heart. So she was sent to a central hospital for urgent surgery. So this is quite an emergency. So there is another type. They're the same thing. It's just they happen in different locations. So type 2 is in the descending aorta. And if you sort of if you remember your like anatomy, it's basically the bit going down after the left subclavian artery that sort of branches off and starts to feed the left arms, I believe. But beyond that, that's your mark point for type B. So those are the types. The important thing in terms of clinical signs and the things they will drop in the SBA will be central tearing chest pain. So normally this word tearing, don't bank on it, but it normally starts making you think this is probably aortic dissection, and you can think of it as like that tearing is the tearing of the aortic wall and the formation of that new compartment. But tearing, that's always how I imagined it, and it typically radiates to the back. Okay. So yes, it can also because basically it can occur in the ascending and aorta around the arch, where you start to form blood supplies going to the arms. It might basically obstruct or restrict the blood supply to one of the arms. And you start to really worry about an aortic dissection if there's a difference in blood pressures of over 20 between the arms. Interestingly as well, if you're sort of doing your cardiac exam, often one of the points of the mock scheme is like doing radial delay to see if there's a difference in the timing of pulses. And this is one of the reasons, because you can pick up what might be an aortic dissection, if blood flow is taking longer to get down one arm, or a pulse is taking longer to get down one arm than the other. You might also see a widening of the mediastinum on an X-ray. So if the dissection is in lower down the aorta, it can also sort of extend down and affect the renal arteries. So if it does that and you stop blood flow going to the kidneys, you're also going to stop basically plasma being filtered through the kidneys, and you're going to stop the formation of urine. So it can cause a kidney failure. And yeah, it can, if it affects the carotids, it will start to have implications for, you know, things like sight and brain function. So it's 25% mortality, so it's quite dangerous. So definitely need to start thinking about getting them to a hospital for surgery. Okay, I think this is the last SBA. So a 77-year-old man is out in his garden. He's gardening, obviously, and he suddenly feels lethargic. He notices he now can't see out of his right eye. He drops the shovel in his right hand, and on examination feels quite weak. The hospital do a CT and an MRI on his brain, and at the it's clear. After 6 hours, he's now regained his sight and right-sided function. What would be the next best investigation?
Would it be the carotid duplex?
Yep. Yes, exactly. That's probably the investigation that's going to tell you something different, or something most relevant in this scenario. So he can't see out of his right eye, so there's something with the blood supply going towards his eyes that's affected, and I think the internal carotid is going to be sort of somewhere around that area. All right, so if you do an MRI of the spine, it's probably not going to explain his eye problems. A chest X-ray, I mean, you've got a CT already, and you've got an MRI of the brain, so you've got, like, I mean, the CT, maybe it won't be the whole body, but there's no lung symptoms, so an X-ray is not going to tell you much. The lying and standing blood pressure is not a bad thought, but again, probably won't tell you anything different about what's happening with his eyes and brain. But it could be it could point to, like, the hand symptoms, possibly. The echo, there's not really anything about. There's not much to suggest there's something wrong with the heart. This is all pointed to something wrong with the carotid. The carotid duplex will help you just delve a bit more into this man's carotid pulse and see if it's well perfused. So great, that's what we'd want to do next. So, oh wow, we've got another one. All right, this one should be quick. A carotid duplex is performed, and it shows that he's got a 45% stenosis of his left internal carotid, and his right internal carotid is stenosed or narrowed to 78%. Yeah, so if you remember, all of his symptoms were on the right side, so this kind of makes sense anyway. Does anyone know the most appropriate management in this scenario?
Would it be A?
Yes, exactly. So the way you can sort of narrow it down quite quickly is if you just sort of know the criteria for when you'd want to do this this operation called a right-sided carotid endarterectomy, which is quite a mouthful. Right, but let's go through the other answers. So in terms of aspirin, you probably want to give him aspirin because we know we can give him aspirin because his CT head is nice and clear. He does not have a hemorrhage. We can give him aspirin. It's probably a good thing to do. Statin, he probably needs one. Right. So yeah, all of these answers at the moment look quite good. You don't want to, in terms of E, that could probably out quite quickly because quite an alarming presentation. You don't want to follow him up in 4 weeks' time. And this one's not doing enough. You want to operate on one of these carotids. You wouldn't want to do both, and that is because basically there's criteria for it. There's loads of different criteria for it, but if the stenosis is typically, if it's above 70%, it's a really narrowed artery, and you want to try and basically cut open that carotid artery and remove that big clogged like basically build up of stuff. So yeah, if it's over 70%, and in an SBA, they're not going to be weird about it. Like they'll make it a little bit more obvious. If it's over 70%, that side needs the endarterectomy. His other one wasn't so bad. It was under 50%. So we could it probably isn't going to provide that much benefit. After this, you can check how it's doing with an ultrasound, and you can do a CT angiography. Okay. And yeah, good to know that if it's really severe, you can start to get seizures and more neurological symptoms. So it might mimic a stroke. I believe that. Oh, do you have a question?
Oh, sorry. Sorry. What was the answer to that question? Because I just missed it.
That's all right. So it's A basically.
Oh, okay. Thank you.
So it's A mostly because his left one isn't blocked enough, but his right one reaches the threshold for being over 70% blocked. And then if it's over 70% blocked, then you can do an operation to basically it's a bit more invasive. You can open up and take out the blockage. Does that make sense?
Yeah, thank you.
No problem. I think that's it. So okay, cool. Thank you guys for joining. It was a long one, but I hope it was useful. And yeah, if there's any questions, yeah, free to ask them now. But otherwise, enjoy the rest of your day.
Thank you.
Thank you.
Thank you.